webinars are made possible thanks to generous donor support. If you'd like to contribute, please visit our website, autism.org.
Well, good afternoon. I want to thank Dr. Steve Edelson and Denise Fulton at ARI and the World Autism Organization for allowing me to share considerations with you on PICA and autism. I'm going to begin with a brief overview of each disorder, the prevalence of PICA in the autistic spectrum, some findings on gastrointestinal comorbidity. Then I'll move into promising treatment approaches and research strategies for future considerations. I'll conclude my talk by introducing my newly coined acronym, SMART, to try to capture recommendations for parents and professionals treating PICA. So very briefly, autism is a neurodevelopmental disorder, most often diagnosed in children 2 to 4 years of age. It has severe repercussions in the social, emotional, behavioral, and developmental domains. PICA is less well known. It's the ingestion of inedible substances and is the most dangerous form of self-injurious behavior, though it has received the least amount of research for self-abuse. Next. Here you see 11 items that I gathered up at our developmental center, all of which have been ingested by clients at Lanterman. And regrettably, this is just a small sample. Some of these items are pretty much innocuous, leaves and grass. Some are dangerous and potentially even lethal. Rubber gloves and plastics can wrap around internal organs and require surgery. Screws and metal objects can puncture internal organs and can require surgery. Other items may seem at first innocuous, but have lethal consequences. I had a client at the center before it closed who choked to death on tags from T-shirts when a laundry room door was inadvertently left unsecured. I'd like to share a case study that I was involved with to treat a 50-year-old man with autism and PICA for cigarette butt ingestion. The data from the residents indicated that this happened 9 to 12 times per month. Neither his advocate sister nor I believed that these data had validity. So we petitioned our clinical director to have testing done at a laboratory on the East Coast to get nicotine and cotinine blood values as kind of baseline. When those values came back, Tommy's nicotine and cotinine values were consistent with that of a chain smoker. Now, I took advantage of Tommy's inclination to hold a red rubber ball in his left hand, and the fact that he loved cans of soda. So we sent him off to his workshop, which was a quarter-mile walk away, with the rubber ball in his left hand and a can of soda in his right hand, which were then incompatible with him picking up cigarette butts on his march. At the end of the journey, he would get to have the can of soda at worksite, and a similar procedure was then employed on the way back to his residence from worksite. We took measurements for 6 consecutive months, and his levels were driven down to 0 nicotine and 0 cotinine in his blood. Now, Tommy was doing very well. I'm excited to say his sister was happy, and that both made the clinical director very happy. We considered this a successful treatment with the laboratory values to back us up. Now, I was able to take advantage of Tommy's natural inclination to hold objects, and this was a fortunate break. In other cases, we don't find such good luck. We've tried, for example, chewing gum, which has been successful in some reports, but more often than not, the clients swallow the gum. We've tried the use of trash bags carried by the clients to put PICA items in, but often there's resistance to holding the trash bags or cooperation, even when staff hold the trash bags. So there's a fair amount of trial and error that have to be pursued, and the chances of success are increased by good observation and knowledge of the client. Can we advance the slide, please? We want to talk a little bit about issues for behavioral treatment. It really becomes an uphill battle to establish effective behavioral treatment. The staff need to be trained and available, which often involves costs that aren't readily met. Treatment averseness. I was able to do a study in 1974. It was the first behavioral intervention for PICA using a timeout helmet contingently for PICA ingestion. I would not consider approval for that kind of procedure today. Environmental restrictions put some limits, some settings off limits to the client who's being treated for PICA, and also for other clients in his group. Many studies can't guarantee generalization and maintenance of gains across settings or over time. And this connects up with some criteria set by the American Psychological Association for what they called well-established, empirically supported treatment, which emphasizes generalization and maintenance, what they call generality. these clinical studies may reach an 80% reduction from baseline criteria, which warrants journal publication, but does not eliminate PICA risk or the problems encountered by interventionists. Next slide, please. Before I talk about prevalence of PICA, I want to mention one other consideration for behavioral treatment. Behaviorists need a compass, a behavioral compass for most effective treatment. And that compass is available to us through what's called functional analysis or functional assessment. Functional analysis helps us to sort through issues that might maintain the continuation of PICA. For example, attention, escape avoidance, sensory issues, or pain attenuation issues. So let me give you an example of what functional analysis might look like for the ingestion of dirt. We might find, for example, that a client always checks out to see whether staff might be looking at him or her when he is about to put a PICA item into his mouth. That may tip us off that the client is really seeking attention to maintain this pattern of PICA. Or the client may ingest dirt or get himself dirty just before it's time to go to work site, and as a consequence be held back from work site, get a warm shower, get the opportunity to go back to bed and possibly watch TV. So here we're talking about avoidance dynamics. Or maybe he or she waits to get to work site before getting into dirt and then necessitate the need to be sent back to the residence to be cleaned up and have the same comforts afforded once he or she gets back there. More often than not, PICA is maintained by sensory stimulation, which is really very difficult to overcome. We might try to find matching foods that provide similar stimulation. So, for example, if we're talking about the grittiness of dirt, then we might try to substitute grape nuts cereals to provide that same sensory stimulation. Or we may try to find other activities that can engage or occupy the client during unstructured times, like playing with electronic games. So sensory matching can be helpful as at least a trial to reduce PICA. Pain attenuation may be related to dental issues, which should be checked out. So now I want to go back to the slide on prevalence. How prevalent is PICA? How big a problem are we talking about? 3.6% of neurotypical or typically developing children display a pattern of PICA, according to data provided by the Center for Disease Control, the CDC, in research done by Victoria Fields and her associates. 4.5% of children with developmental disabilities other than autism display PICA. 23.2% of children with autism spectrum disorder display pica. And there's one study from 1985 that recorded 60% of adults with autism displaying pica. And this author, Cannell, even suggested that pica was diagnostic of autism. So another question to ask are GI signs and symptoms and diseases more prevalent in developmentally disordered persons with pica compared to corresponding peer groups without pica? The answer is a resounding yes. And I'd like to try to draw a through line through two parent survey large sample data sets, each with more than 2,000 children. The first study is done by Fields, Nakub, and Sok in 2020. Those researchers looked at patterns of vomiting, diarrhea, loose stools, constipation, and pain on stooling. They then presented pairwise comparisons for autistic children with pica versus children with autism only, and then also for developmentally disabled children with pica and developmentally disabled children only, so that across these 5 symptom patterns, we had 10 pairwise comparisons. All 10-wise comparisons showed a higher prevalence for the children with pica compared to those without pica. So, for example, for diarrhea, the autism group with pica had a percent occurrence of 17.4% versus autism only 11.9%. For the developmentally disabled children with pica, 15.2% versus the children without pica, 5.5%. Not dissimilar data are available through the Autism Research Institute, reported to me by Steve Edelson. For the children with autism and pica, prevalence for IBS was 58% versus for the children without pica, 42%. For GERD, the children with pica had an occurrence rate of 55% versus 45% for the children without pica. And interestingly, food craving for children with pica was 58% versus 42% without pica. In the study that I did with my adult population at Lanterman with colleagues Stan Lundy and Dale Berger, we found even more dramatic results. Next slide, please. Here are the groups that we looked at and broken out by gender and age and according to diagnostic group. We had 4 groups, one with autism only, another with autism and pica, a third with pica, and a fourth with a control group for developmentally disabled clients who were had no secondary diagnosis and were matched to the pica subjects on age and gender and level of cognitive function. The age range, as you can see, is 24 to 58 years of age. There were predominantly more males in the two autism groups, but that's not surprising. So I want to show you the dependent measures we used in the next slide, please. Here you see a comprehensive checklist of 21 signs and symptoms on the left and 19 diseases on the right. The checklists were carried out by 2 UCLA pre-doctoral psychology interns who were blind to subject assignment and blind to the purpose of the study. They were trained to search through a 10-year period of medical records. The inter-rater reliability was 94% over randomly selected charts. May I have the next slide, please? So I want to start off by presenting data before I present data for the individual groups, I'd like to present data that highlight the impact of the presence and absence of PICA, which was the most significant variable that we looked at. So the PICA group here is the combined groups for PICA and autism PICA, 33 clients in total, and the no PICA group is comprised of clients from the autism only and control subjects, the developmentally disabled subjects with no secondary diagnosis. So you can see here that for in the combined groups, the percentages, the prevalences were consistently higher across all of the 10 most frequently occurring diseases for those clients with PICA compared to the no PICA clients. Typically, the PICA clients had prevalence rates that were 2 to 3 times higher and even more dramatic when we looked at ulcer, H. pylori, and aerophagia. Next slide, please. Here are the diseases broken out by diagnostic group. If we start with the shaded column on the far left, that represents the PICA-only clients, and they averaged 2.25 diseases per client. The next column to the right, the white column, represents our control subjects, and they averaged 1.31 diseases per client. The tall shaded column to the right represents autism PICA, and they averaged 2.88 diseases per client. And finally, the far right white column represented our autism clients, who averaged 0.53 diseases per column, per client, excuse me. So we find the two autism groups at extremes in our graph here. If we looked again at combined groups, the individuals with PICA averaged 2.6 diseases per client versus those without PICA, less than 1 disease per client. very dramatic differences. I really like the explanation offered by renowned clinician and researcher Richard Fox, who says over the years, pica takes a severe toll on the body. And that is backed up by other literatures for showing shorter life expectancy and higher mortality rates for those with pica. Our study suggested that individuals with both autism and pica may be a phenotypic subgroup on the autism spectrum, characterized by GI symptomatology and requiring a clinical algorithm for categorization and effective treatment. Next slide, please. Here are several nutritional interventions, zinc and iron supplementation studies done some time ago, showing promise for these kind of supplementation strategies. And I'll be talking a little bit more about zinc shortly. Polyvisol is a liquid multivitamin comprised of 10 vitamins, which effectively reduced pica for a single client. The most impressive study listed here was done by Bugle and Rubin, utilizing standard vivinex, a formulation of 22 essential ingredients in a readily absorbable form. These researchers were able to utilize this drink to reduce coprophagy, the ingestion of feces, which of course has pernicious health repercussions and social repercussions as well. They did so utilizing a very powerful research design that incorporated both reversal elements and multiple baseline elements. And of course, this kind of approach sidesteps the issues of having staff available for pica intervention. It's not dependent on practitioner availability, and kind of looks to issues of generality. I would say that this study deserves the description of well-established, empirically supported treatment. Next, please. This study, the study on zinc supplementation, antioxidant therapy, which includes vitamins C, E, B6, magnesium, and manganese if warranted. The best work in this area for me was done by Russo and DeVito in 2011 in an article entitled Analysis of Copper and Zinc Plasma Concentration and the Efficacy of Zinc Therapy in Individuals with Asperger's, PDD, NOS, and autism, all, of course, on the autism spectrum. They focused on the importance of a high zinc to copper ratio. And one hypothesis is that zinc induces the synthesis of copper-binding metallothionein in helping to suppress higher copper levels. A wonderful study by Jill James and her associates established that the metabolic profiles of autism spectrum disorder children and typically developing children differed significantly. And they used corrected, observed, they utilized targeted nutritional intervention, folinic acid, betaine, methyl B12, to correct observed metabolic imbalances. And this study was very heartening because it suggests that certain aspects of autism are treatable. It also suggests the possibility of a metabolic phenotype. The further work has been done by Kong and Adams in the United States, and Zhu and Li in China, to show that there are relatively lower abundances of healthy bacteria in the guts of autistic children and higher abundances of unhealthy bacteria and less diversity in gut bacteria. So the issue here is that healthy bacteria are needed to reduce susceptibility of infection, to aid in food digestion, vitamin production, and protection against harmful bacteria that can ultimately affect the gut, brain, and the rest of the body. Their emphasis here is to use procedures that help to repopulate or recolonize the gut colony, one of which is microbiota transfer therapy. But I'd like practitioners to put that sort of on the back burner for now, because there are other therapies that I would say are useful as first lines of defense, including diet, probiotics, prebiotics. I would refer people to an article by Ristori and her associates called Autism, Gastrointestinal Symptoms and Modulation of Gut Microbiota by Nutritional Interventions, in the journal Nutrients 2019. So let me draw a through line through these studies and connect it up with the research that I've done with Dr. Stan Lundy and Dale Berger. We would hypothesize the greatest disturbance in function, i.e. the greatest deviation on these types of biological measures for clients with autism, PICA, compared to other groups, autism spectrum disorder only, developmentally disabled, or typically development clients. In other words, when PICA is in the mix, the stakes are higher metabolically and certainly for gut disturbances. I'd like to give a shout out to the work done by Jim Adams and his associates in a study titled Comprehensive Nutritional and Dietary Intervention for autistic spectrum disorders, a randomized controlled 12-month trial. This study utilized 6 stages of nutritional diet intervention to produce significant changes in cognitive, social, developmental, and behavioral domains in 67 autistic children and adults ages 3 to 58, compared to 50 neurotypical control subjects. Both the study data and parent report suggested that a comprehensive vitamin mineral intervention and fish oil supplementation carried the greatest benefit for the subjects in this study, and these 2 regimens were the ones that parents wanted most likely to retain at study's end. But in terms of our focus on PICA, I want to present one of 3 case studies that Jim Adams called out for a 7-year-old child with severe PICA. 1 week after this child was introduced to the healthy, safe, casein-free, gluten-free diet at one of the stages of intervention, the PICA completely resolved. So what's the takeaway that we have at this point of the discussion? One can look toward the manipulation of behavioral antecedents and consequences to help try to reduce PICA. One can look to changes in diet, whether it be the casein-free, gluten-free diet or the Mediterranean diet that Ristery also suggests may be very helpful. Or one can look to identify vitamins or minerals that may be lacking or deficient in a client with PICA as different kinds of approaches. And we really have to be open to trying these 3 different strategies to see which might be most effective in providing benefit. I'd like to conclude this slide with a look at some homeopathic work that I did together with Dr. Ron Frank, treating a young man who is now 15, beginning when he was 11, someone who had very poor prognosis in terms of responding to treatment, certainly not a candidate for discrete trial or many of the ABA types of approaches. This child, Andrew, was very limited in what he would eat. Pretty much his diet was built around chicken nuggets. His eye contact was almost non-existent. He was resistant to get his hair cut, to go to school. Very, very low functioning autistic young man. And now, 4 years later, through Dr. Frank's homeopathic recommendation and me with some supplemental behavioral recommendations, this young man is doing exceedingly well. He is flirting with some of the girls, some of the women in his classroom, smiling at them, occasionally tousling their hair. He is playing simple games at school and at home. He seeks out family time. He offers help to his younger brother in getting things down from high shelves, and accepts help with the remote controls from his younger brother. In terms of communication, this young man who has never had any speech whatsoever now has several clear words, such as hi and bye, has 8 of the hard consonant sounds, which lead to approximations recognized by his parents. He also utilizes waving and nodding as part of his communication. He allows the barber to give him haircuts, likes to go to school. That's part of the routine that he really appreciates. His tantruming has significantly decreased. And in terms of quality of life, there looks like there's been a overall reduction in his anxiety levels, which have in turn led to improved sleep, possible reduction of sexual tension, masturbation, self-stimulatory behavior. His pica behavior is pretty much dropped out, except under conditions of high stress. So during a period of time when the family made multiple trips to Texas to provide care to this young man's ill grandfather before he passed away, the pica increased along with other measures of aberrant behavior. Also, he's much more open to experimentation with different types of foods, and overall high marks from his parents in terms of having this young man at their home. When I look at the homeopathic formulations that Dr. Frank utilized, there is overlap with the very comprehensive program that Dr. Adams introduced. Jim Adams' regimen contained 31 vitamins and nutrients. Ron showed overlap in his homeopathic regimen with zinc, fish oil supplementation, a range of B vitamins, but also some differences in compounds for calcium, zinc, and magnesium. Dr. Frank introduced calibromatin once every 3 days to help reduce anxiety, and alfalfa, which is highly mineralized and also contains a range of B vitamins. So I would love to sit down with Dr. Adams and Dr. Frank and discuss optimal diet and nutrition. May I have the next slide, please? Oh, we're to references. Okay, you can please go back. Let me conclude this lecture by utilizing my treatment recommendations captured in a acronym that I call SMART, S-M-A-R-T. S for safety. Important, of course, to utilize common sense and precautions to help with safety. Many of our clients have multiple PICAs that they demonstrate. And so a walk in the park may not be a walk in the park in terms of the need to intervene and be cognizant. Similarly, a theme park may not be a good setting. A single episode of pica can be dangerous, even lethal. Let me move on to letter M for medical issues. Medical issues, of course, should start with the family physician, but as indicated, we may want to expand the team to include a gastroenterologist, dentist, and nutritionist to help rule out all possible medical issues. Issues may present themselves around eating, for example, a very restricted kind of diet, like for Andrew, the chicken nugget diet, or also very strong food craving. We also may want to watch out for abdominal pain, vomiting, stomach ulcer, repeated need for antibiotics, possible lead poisoning, and mouth sensitivities. So a nutritionist on board can consider other types of diets, gluten-free, casein-free diets, along with the Mediterranean diet. And again, I would encourage a dietitian to look at the Ristery article in Nutrients 2019. A caution here, deficiencies may occur in the context of a balanced diet due to issues of maldigestion and malabsorption pointed out by John Pangborn and his associates. Consider phenotypes in your decision making, and consider that pica may be a red flag for GI symptomatology, and conversely, that GI signs and symptoms may be a red flag for pica. Early intervention is preferable, not surprisingly, to offset a poor developmental trajectory. Let's go to the next letter, A, for analysis. Analysis or assessment. We've already talked about functional analysis or assessment, and the importance of it. We want to make sure that we're not barking up the wrong tree. Letter R in our SMART acronym is for reinforcement inventory or reinforcement menu. Doing a menu or an inventory can provide us with important options, not only to help us with any kinds of differential reinforcement strategies we may choose to employ, but also in identifying activities that are incompatible with pica ingestion. So, for example, with Tommy, the use of the red rubber ball and the can of soda showed up on a reinforcement inventory along with cans of soda. I would suggest an inventory of at least 50 items that you can access online. And finally, the letter T for treatment package. What I mean by that is a combination of treatments. We, as persons who have been involved in private practice, we know that oftentimes the combination of psychotherapy and pharmacological treatment can be most efficacious, particularly in attempting to address immediate and long-term concerns. A treatment package may be optimal. Similarly, we may want to put together a treatment package that utilizes a combination of behavioral approaches and nutritional supports to help address immediate needs and long-term needs in children and adults with PICA.